Kong, Dr. Ollie. Nice to meet you here. I would like to introduce to you Dr. Ollie, Dr. Yu. Dr. Ollie Yu, she is a clinical assistant professor in cariology. And cariology there is a division from restorative science in the Faculty of Dentistry, University of Hong Kong. And currently she is the cariology course leader in the university. Also, she did her PhD in the University of Hong Kong with outstanding papers. And also she is a great researcher and she received many grants. So I wouldn't like to take a lot of from your time, Dr. Ollie. So I will keep you, just go for your lecture. Thank you very much for accepting our invitation in a very short notice. And I think your participation today and contribution is highly appreciated. I try to convey all the regards from the administration team in the Faculty of Dentistry, as well as from the department chairman, Professor Salah. Thank you very much, and we are waiting your lecture. Thank you.
Thank you, Dr. Hamama. So now I'm going to share my screen. So can you see my screen now?
Yes.
But not in full screen, right? How about now?
This is now the first screen. We can see the full screen.
Okay. So good afternoon, everyone, and students and colleagues. Thank you so much for the invitation. And I'm Dr. Ollie Yu. So I'm from University of Hong Kong. And Dr. Hamama has already given a very detailed introduction to me. So I won't have to repeat that again. So let's start with the title of today's sharing. So the title I'm going to share the conservative resin composite restoration, the shift of paradigms in cariology today. So this is the learning objective today. So by the end of the lecture, you should be able to apply the medical models in your practice to manage dental caries, and you should be able to describe the principles of caries removal and cavity preparation. And you'll be able to list different caries removal techniques and cavity preparation techniques. And you'll also be able to select caries removal techniques and caries preparation techniques for your patient. So this is the outline today. First, we will introduce what is medical model and the medical model in caries management. And then the principle of caries removal and the cavity preparation. So in the last part, we will talk about the conservative direct restoration with resin composite with 2 clinical cases. And here is the QR code, so you can scan. So before we start, we need to know what is caries management. Caries care or management or the caries control actually are the actions we are taking to interfere with the mineral loss at all stages of caries disease. And because the continuous of this demineralization or the remineralization process, caries management actually need to be continued throughout the life course. So when you talk about caries management, what is the first strategy you will come up with? Is to remove the caries lesion or to restore the cavity with restorative materials? So this is the question you have to ask yourself. So sometimes when we talk about the caries management, we will mention caries model for caries management. And what does the model means here? And what is the component of caries management, or what should be included in a caries management? And the caries management can be broadly, to answer these questions, so it can be broadly classified into the non-operative or the operative interventions or the treatments. So the model here refers to the philosophy of treatment or the rationale of the treatment. And surgical model refers to the operative approach to treat dental caries. So what is medical model? Medical model, it plays the medical approach or the non-operative approach in priorities when we are managing dental caries. Traditional caries management is to remove the caries tissue with dental drill, and then we will fill it with the materials to restore its morphology and the function. So in other words, the caries was managed primarily by surgical model, but this model was not recommended anymore. So to understand these reasons, we have to understand the shift of the concept in the cariology. So the understanding of dental caries has changed greatly in the past 20 years. In the past, dental caries was regarded as an infectious disease. And the diagnosis of the dental caries is made based on the presence of cavitated lesions. The strategies to treat caries or to treat this infectious disease is to control the infection. And in most cases, we will remove the infectious tissues. And this is the reason why in the past, caries was treated majorly by operative strategies. And the dentists believe that the caries lesions need to be completely removed to prevent the recurrent caries. But now the understanding of caries has changed. So it's now regarded as a non-communicable and a dynamic disease. So the caries should be diagnosed in an early stage. And caries include non-cavitated and cavitated lesion because it's a dynamic disease. And early preventions and interceptions is important to reverse the disease. So because of the understanding of caries as a disease has changed, so the contemporary paradigms of caries management has shifted as well. The paradigm in the caries management embraced the principle of minimal intervention dentistry, and I believe that you heard this principle for many times already. So caries was treated with surgical model in the past. And then the surgical model will remove the caries lesion, which is the sign of dental caries as a disease. So the philosophy of surgical model, it treats the signs and the symptoms of caries. And the surgical model reverses the damage of dental caries by restore the shape and the function. So the surgical model cannot prevent the recurrence of dental caries. But the medical model will follow the principle of minimal intervention dentistry. It tackles the etiological factors and the risk factors of dental caries. So the reverse of caries management is achieved by stop the demineralization and remineralize the dental hard tissue. That is why the medical model can stop the dental caries by stop the progression of the disease. So why we need to manage caries with medical model, or why surgical model is not suitable for caries management? Actually, this figure shows the life cycle of a tooth if we treat the caries with surgical model. So first, caries will be removed when the caries is still reversible, or we will remove the non-cavitated caries. And then the cavity will be created and restored with restorative materials. But with the current available technologies or the restorative materials, they have limited lifespan. So it can only last for a few years. So they will fall off after several months or several years. So when the materials fall off, the restoration will be needed. And then cavity will enlarge because of the cavity preparation and also the remove of the secondary caries if the new caries has developed. And then finally, the result would be that too much tooth structure will be lost. And in the process of filling and the refilling. So the final destiny of these poor tooth is to be extracted. And Caries model aims to, so the medical model aims to intercept the dental caries in early stage and prevent further development of dental caries. So it will extend the lifespan of a tooth. That is why caries should be treated with a medical model. And here's the aim of using the medical model for caries management. First is to improve and maintain a person's dental health and prevent caries from recurring. We also aim at stop caries from progressing and reverse the damage caused by caries. The most important is that we want to prolong the lifespan of the tooth. So I think we're quite familiar with the etiological factors that is directly related to the caries management. And here's 4 factors that is essential for dental caries development. We have bacterial, we have diet, we have the susceptible hard tissue, and we also have time. And caries will occur with the presence of all these 4 factors, right? So if we remove one or more etiological factors, then caries won't occur. And medical model actually adjusts these etiological factors. So that is the essential components of the medical model. Is to use plaque control to eliminate the bacterial factors, and then to reduce the risk levels, including the carcinogenic diet, and the long-term follow-up, and also the preservation of the dental hard tissue or remineralization. So now let's take a look at these 4 factors one by one. The first component of the medical model are plaque control. So this is aimed at remove bacterial as a etiological factors. Oral hygiene instruction is the first strategy to control dental plaque. And the oral hygiene instruction is the chance to develop that your patient knows and understands why you want them to achieve good oral hygiene. And this discussion should also include a simple explanation of the role of dental plaque. And you can also demonstrate some appropriate hygiene aids and their use to the patient, and then evaluate the use of these aids. So how effective is oral hygiene instructions in remove dental plaque? This is a systematic review. It evaluates the effect of oral hygiene instruction in improving the oral hygiene and the dental caries in preschool children. And this review suggests that the reinforcement of oral hygiene instruction or the oral hygiene education provides further benefit in reducing dental plaque. But solid association between the oral hygiene instruction and dental caries has not yet been proved with the current evidence. Another factors in the plaque control is the mechanical plaque control. And mechanical plaque control are the major means to maintain the oral hygiene and the mainstay of preventive treatment. So tooth brushing, including the manual or the power brushing, should be recommended as the primary means to reduce the dental plaque. And we can also use the interdental hygiene, and the selection of these interdental aids should be based on the interdental anatomy. The patients can choose the interdental brushes or the flosses or the oral irrigators according to the anatomy of their interdental space. So this is a Cochrane review showing the effect of the home-use interdental cleaning device with toothbrushing in controlling dental plaque. And this review answers the research question about the effectiveness of home-use interdental cleaning device with toothbrushing versus toothbrushing alone. And it was testing the effect of preventing and the controlling of periodontal disease, dental caries, and dental plaque. So this review finds that using the floss or the interdental brush in addition to the toothbrushing can reduce the plaque or both more than the toothbrushing alone. And the interdental brush may be more effective than floss. But available evidence for tooth cleaning sticks and the oral irrigators is limited and inconsistent. So another commonly used approach is to use the chemical agent for plaque control. The chemical plaque control is delivered primarily through the agent, such as the toothpaste, the mouthwash, the dental gel, or varnish. So the active antimicrobial ingredient in these agents, including chlorhexidine, the xylitol, and the other antibacterials. So chlorhexidine is an antibacterial antimicrobials that suggest for anticaries use, but research conclusions have been inconsistent. And this review, actually, there are reviews investigating the effectiveness of chlorhexidine in preventing tooth decay. So this review was published in 2015. It works on the chlorhexidine treatment, conclude that the evidence for the chlorhexidine varnish or the gels to prevent caries or to reduce the S mutans count is quite weak. And there's no trial on other products containing chlorhexidine. For example, the chlorhexidine space, chlorhexidine toothpaste, or the chewing gums or mouth rings. So that means that the data is not solid. And here's another review, and this review works on the products containing the xylitol. So it's sweeteners that can be used in products and to help to prevent tooth decay in children and adults. And these conclusions are that the evidence is low for the xylitol with fluoride varnish or the toothpaste in preventing caries in permanent teeth. There's insufficient evidence for the xylitol containing products in preventing dental caries. So the second element for the medical model is to reduce the risk level, which aims to remove the etiological factors such as carcinogenic diet. So we can follow this sequence or the steps to reduce the caries risk level. And the sequence first starts with an identification of caries risk factors by the clinician. And we can gather all the informations, the caries risk or the future caries incidence can be assessed. And then we can customize a preventive plan according to the patient's clinical conditions or the social demographic backgrounds. And the final step will be implement the treatment plan in order to manage the caries disease in the most effective and the practical manners. So we have several caries risk assessment tools now, and these two are two common use tools for caries risk assessment. They are caries risk assessment forms. And the left one is originated from, the right one, sorry, is originated from Canberra. The caries management by caries assessment, and it was originated from California Dental Association from 2002. And the right ones and the left ones are the caries risk assessment forms from ICCMS. So the caries management plan incorporates risk reduction strategies from many perspectives. It involves the professional advice and the treatment from the clinician, and also the behavioral or the lifestyle modifications of the patient. And caries reduction is an integration of these approaches. First, the diet analysis and advice to reduce the sugar intake. And then we need to control the plaque by reinforce the oral hygiene and the use of chewing gums to increase the salivary protection. And also there are dental sealants to prevent fissure sealants and the use of fluoride. So the other components of medical models are long-term follow-up. In successful dental health maintenance, it relies on the long-term follow-up. And this component actually is the last step of the caries management because we want to focus on the remineralization and the prevention and the preservation of dental hard tissue. So we move it a little bit forward. So the follow-up has three aims. The first is to reevaluate the outcomes of the caries intervention. And the second is to screen for the new caries lesions so that the disease can still be managed in its reversible stage. And also to plan for new intervention if necessary. And without an effective recall system, the effect of the successful intervention actually may be compromised or gradually decreased until the patient returns to the inertial levels of caries imbalance. So the last components we are going to talk about today in the medical model are the remineralization of teeth or the preservation of dental hard tissue. And this part is essential in arresting caries with non-invasive methods and also in preserving the dental hard tissue when we are doing the caries removal. So the approach of the remineralization of tooth in the medical model is able to heal the caries in an early stage. It can partially reverse caries damage in a more advanced stage, and is more effective in an early stage of the disease. So it's important to detect and to remineralize the caries lesion early. And this approach has several advantages, such as we have plenty of choice in the products, and it's very simple to apply, it's painless, and it costs less compared with the surgical interventions, talking about the drilling and filling methods. So we have a lot of products containing the remineralization agents that has been available. Most of them contains fluoride, calcium, or the phosphate compounds such as the CPP-ACP, the functional tricalcium phosphate, and you can choose one or choose different type or forms or the concentrations for your patient according to and you can also choose the home use or professional use. So in some cases that the restoration is needed, then how do we preserve the dental hard tissue must be taken into consideration. So now I want to spend some time to explain the preservation of dental hard tissue in the restorative procedures. So in patient that a restorative procedure is needed, we need to remove the active caries and design the cavity before we fill the cavity with restorative materials. And there are some principles we need to follow when we restore the caries. The principle of caries removal in the cavity preparation is to preserve the pulpal vitality, to develop a retentive cavity, and also to provide a restoration which will withstand the normal function stress until a final decision is made. So to better understand, let's take a quick review on the histopathological structure of dental caries. So you can better understand the principle of caries removal in the cavity preparation. So you can see this picture or these photos. The purple part are areas that contains bacteria, and the yellow parts are the dentin. So on the top of the lesion is the zone of destruction, and then beneath it is the zone of bacterial invasion. The other purple part have bacterial invasion, and then below the bacterial zone there is zone of demineralization, and then underneath the demineralization area there are translucent zone or the sclerosis zone, and then the layer close to the pulp, which was in the green rectangular. It was close to the pulp, and that was reactionary dentin. So according to the bacterial infections in the hard tissue, we will classify them into infected dentin and the affected dentin. The infected dentin are consist of the zone of destruction, zone of bacterial invasion, and also the superficial portion of the zone of demineralization has part of bacterial. And the affected dentin is the deep portion of the zone of demineralization, and it has also the hypermineralized area, such as the translucent zone or the sclerosis zone, and also the reactionary dentin. They are affected dentins. So theoretically, we know that we need to remove the infected dentin and preserve the affected dentin. So clinically, actually, we don't know, or we cannot really tell the existing bacteria in the caries lesion with our eyes. In the past, some dentists will use some chemical dyes to stain the caries tissue, and it will work as an indicator for the caries removal. But these dyes actually they diffuse too much, and that will cause over preparation in the cavity. So now the practical way is to connect the histopathology of the caries to the tactile feelings, and is more abstract, or it's not that precise, but it's more practical. So if you do a tactile investigation with a round head probe, you will feel the infected dentin is normally soft. So you can see the pictures on the right side. So we have a hardness distribution of the caries lesion here. And the infected dentin is normally soft. The affected dentin is normally leathery or firm, and the sound dentin is hard. So caries removal techniques can be classified according to the amount of the removal tissue. In the past, we will non-selectively remove all the caries dentin from the cavity until the dentin is hard. So if you see from this figure, you will find that this method remove dentin that is not infected. If you remove all the hard tissues until to the dentin, then you remove the translucent zone. So this approach is no longer recommended. And in the cavity preparation for the shallow or the moderately deep lesions, we will use selective removal to the lateral or the firm dentin. So this means to remove soft infected dentin and to leave the affected dentin, which is lateral or firm or hard and hard. And the superficial layers of the affected dentin is sometimes stained, but we can leave it. We can leave this discolored dentin as long as it does not affect the aesthetic of the restoration. And in the cavity preparation for the deep cavitated lesions, we will choose selectively removal to soft dentin, and then we will leave some soft dentin close to the pulp to avoid pulp exposure. And this may have some infected dentin left, but that is the compromise we need to make if we want to preserve the vital pulp. And then we can use some antimicrobial conditioners or liners for the disinfection of the infected dentin. So for the peripheral walls of the cavity, we need to leave hard dentin to make sure the cementation and to make sure that the marginal seal of this cavity. So in the cavity preparation of the deep lesions, we can also remove caries tissue stepwisely in 2 stages. And in the first step, the soft caries tissue is left over the pulp. And in the second step, the caries tissue removal continues until the lateral dentin remains over the pulp. And this stepwise caries removal, it allows the generation of the tertiary dentin or the reactionary dentin, but it's not recommended for the primary teeth. And this technique is no longer recommended. So the cavity design normally accompanied with caries removal. And the cavity design was determined by the structure and the property of the dental tissue. And the disease, such as the caries, the pathological tooth wear, the fracture, the periodontal disease, and also the property of the restorative materials. So up to now, we have a brief introduction on the medical model on caries management. But how can we apply this medical model in the restorative cases? So actually, the medical model can be incorporated into our treatment plan for the patient. The plaque control and the reduction of the risk level can be applied in the preventive phase or the corrective phase. And then the preservation of the dental hard tissue will be executed in the restorative phase. The long-term follow-up will be performed in the maintenance phase. So now let's take a look at some clinical cases on how to preserve dental hard tissue in the restoration of the caries tooth. So the clinical case 1 was a 35-year-old woman, and deep caries was found in the upper left premolar. So this is the clinical photo before restoration. The deep caries was found in the distal occlusal area with proximal surface involved. And then the distal marginal ridge was destructed. So in the fissure area of the occlusal surface, the microcavitated enamel caries was found. But luckily, this bi-wing showed that the caries was not yet developed into the pulp. And then we do the pulp vitality test. The pulp is alive. And then the traditional caries removal approach will remove all the caries in the proximal surface and then extend along the fissure. So that means that if you remove all the caries tissues, then the cavity may end up with a dovetail outline form, such as the classical ones for the amalgam restoration. So this cavity was very close to the pulp in this case. And before we start to do the restoration, we need to decide which caries removal technique should be used. So this paper, it compares 3 caries tissue removal techniques to see which one offers the lower risk for the permanent teeth. The conclusion is that the selective caries tissue removal actually presented higher success in maintaining the pulp health. So this review suggests that for permanent tooth, selective caries tissue removal should be performed. Therefore, we can use the selective caries removal to remove the caries in this case. And here's the photo after caries removal. We selectively remove the caries to firm denting in the proximal area. And then a box-only outline form was prepared with the preservation of the fissure area. And then the denting is very close to the pulp. So then we will line them with glass ionomer liner. So you see there is a small glass ionomer liner in the denting part. And then a sectional matrix system was placed for the separation of the contact area with the adjacent teeth. Then we do the acid etching and on the enamel and use a 2-step self-etching bonding system. Then we use a thin layer of flowable resin composite into the floor of the cavity and lacquer them as the second layer of liner. And later, the distal proximal wall of the tooth was built up with the resin composite. So after we have the proximal wall, we remove the sectional matrix and clamps to check any voids in the external surface or the proximal composite walls. And then the cavity was filled with resin composite using the incremental layer technique. So this tooth was restored with modified sandwich technique. We used GI and the flowable resin composite to do the double lining before the restoration. For the conventional sandwich techniques, it built the resin composite on top of a GI liner. But some concerns are that the micro leakage would be severe in the interface of these two materials. So we will use GI liners to cover a small part of the dentin that is very close to the pulp. And then the rest of the floor of the cavity, we cover it with the flowable resin composite as a second liner. So because the flowable or the self-cure composite liner generate less micro leakage than other lining materials, as shown in the papers here. And for the oblique incremental restoration techniques, it was used to reduce the inner stress resulting from the polymerization shrinkage of resin composite. And here is the evidence support. So after restoration, we use sealant to cover the microcapitated caries in the fissure area, which may be removed if we follow the old principle of caries management. So the effect of fissure sealant in caries management is in fact underestimated. So if we go through the literature, you will find that fissure sealant actually is used not only in caries prevention, but also in caries control. This is the Cochrane review published recently, and it shows that the sealant reduced the caries between 11% and 50% compared to no sealants at the time point up to 48 months. So in the past, we will remove caries and restore the cavitated caries. But if you see the result from the study in the lower rows, you will find that the sealant is actually quite effective in arresting caries. So regardless of the lesion severity, actually the sealant was 100% effective at the 12 months and 98 effective over the 44 months in managing occlusal surface at IC 0 to 4. That means that some of the caries are cavitated or microcavitated. So this is the final look of the teeth after the restoration. And the restoration is very close to pulp. And we will keep the vital pulp, then the most of the tooth structure with the conservative cavity design and the composite restoration. So here is the second case. A 36-year-old female with deep caries in the upper right second molar. So for the oral examinations, we can see a cavitated enamel caries in the fissure area of the occlusal surface, and the marginal ridge was not involved. So this bywing shows that the caries lesion was undermined from the occlusal surface to the mesial proximal surface. The middle third of the dentine was involved, but the marginal ridge, the enamel marginal ridge, was intact. And we assess the proximal caries through the fissure area of the cavitated occlusal surface. The caries tissue was removed from the occlusal, assessed with the burr, oriented mesially, and then the infected dentine with soft texture was removed until the firm affected dentine was remained. So after caries removal, a tunnel under the mesial marginal ridge was built, and the sound mesial marginal ridge was remain intact. So because the structural loss in the proximal surface, the marginal ridge is kind of unsupported. And if the height of the marginal ridge remains too short, then it tends to collapse. So what is the appropriate height of the marginal ridge after the tunnel preparation? So this interesting study, it compares the strength of the tunnel preparation with the marginal ridge of 1.5, 2.5, and 3.5 centimeter. It found that the premolar tunnel restoration with composite at 2.5 distance from the marginal ridge was as strong as sound teeth. So what if we keep the height at 3.5 millimeters? Will it be stronger? So theoretically, maybe yes. But if you keep a 3.5 millimeter height, centimeter height marginal ridge, then because the orientation of your burr cannot change much, then that means that you may need to insult the pulp chamber. So after the tunnel preparation, we place the tofoamine matrix system and then acid etch and restore the tunnel with the resin composite. So here's another question. In the past, the tunnel preparation was restored with GIC, but this review investigates the available informations and the clinical success of the tunnel restoration. And the result shows that the GI tunnel restoration has higher failure rate. So talking about 7 to 10% annual failure rate. So through this review with all the available evidence, it suggests that the composite tunnel restoration is more compromising. So that is why we choose the resin composite restoration in this case. And here is the final look of the restorations. Thank you for your attention. So actually this case report has been published, and it's a collaboration work between the University of Hong Kong and the Mansour University. So I would like to thank Dr. Hamama and also Dr. Ahmed for their contributions in this case report. So your questions are welcomed.
Thank you, Dr. Yu, for the nice presentation. It's really amazing. Also, it gives a whole aspect between cariology and how cariology, the development in cariology is linked to the cavity preparation. It's very, very formative, okay? And I really enjoyed it. So now we are opening the space to the panel, the floor to ask questions. So please, guys, if you have any question, just raise your hand. Or if you just would like to write it in the text, I think Dr. Yu Chi will happy to answer all this. Thanks. So now it's open. So if you have any conversation, any text or any question in your mind, please write it or raise your hand and we will just give you the mic to ask Dr. Ollie. Dr. Ollie, until we get questions, maybe I have a question. Okay. So please, Dr. Ollie, when you know that there is some debate about the tunnel preparation. So when we go for the tunnel preparation, you would like to make it as an open sandwich technique. So I put the glass ionomer, which face the external environment, I mean the oral cavity, or you would like to put a flowable composite to seal this area, then fill it like a closed tunnel or closed sandwich technique. Which one you would prefer for that?
You mean for the flowable resin composite?
Yeah. We because you know that there's two techniques. One of them just to seal the glass ionomer to make it doesn't expose to the oral cavity directly. So they put a small layer at the beginning on the matrix system. Then they put the glass ionomer, then seal it again from the enamel surface with composite. Or do you prefer to just put the glass ionomer and until to the end of the matrix system or the band?
In the tunnel preparation, right?
Yes.
So for the tunnel preparation, if we just use the GI, the glass ionomer cement, actually the strength is not enough. That is why there are some cases report that if we use the glass ionomer cement only, then we have very high failure rate annually. And for the other method is to use the resin, flowable resin composite, and then as a layer, and then use the GI. But I think this one is still not that recommended. For now, they are more prone to use the resin composite as the restorative material to build the whole tunnel. So unless the area is very close to the pulp, or I think the resin composite would be a good material for the tunnel restoration.
Thank you very much. Now we have a question now from Dr. Hisham. He asked about what about using universal pond directly on selective caries removal technique?
What about?
You can put the question on the chat panel. He asked about what about using universal pond directly on selective caries removal technique.
So actually this is two parts. For the selective caries technique is the technique on caries removal. And then for the universal bond actually is the technique in the restorative part. So actually this is two questions. And then after the selective caries technique, you mean the after selective caries technique, then we may have some affected dentin remains, right? But for the universal bond, but for the peripheral part or the peripheral wards of this cavity, actually we remove all the caries until sound. So that means that we have a sound dentin wards for the marginal seal or for the whole bonding systems to attach on. So it's okay to directly bond it after the selective caries removal.
Thank you. Thank you very much, Dr. Yu. And we have now an opportunity also, and this is a good Professor Salah. He is the chairman of the department. He's already here. He welcome you, and also welcome all the audience, because there is some problem in the connection here. Okay.
Hello, Professor.
We are so lucky that he is in your lecture. Yeah. Just a moment. I will open this. Dr. Salah.
دكتور حمدي.
ازاي حضرتك؟ اخبار حضرتك
ايه؟ There was a problem for connection.
Okay.
Solved
We
now.
are happy, and Dr. Yu, we are lucky that we have you in Dr. Yu's lecture.
Thank you for your great effort, dear friend Dr. Hamdi, and thank you for Dr. Yu. Dr. Yu, thank you very much for sharing this event. I hope to be in good state. Yeah. Thank you.
Thank you so much for the invitation.
دكتور صلاح، عاوزين بقى حضرتك ترحب بالاودينس بقى، لان حضرتك احنا طبعا زعنا كلمه الترحيب في الاول، لكن حضرتك معانا لايف بقى.
كان انا عندي مشاكل، انت عرفت انا حاولت اتصل بيك كتير يعني، طبعا كل الشكر والتقدير لكل المشاركين في هذا اليوم العلمي الجميل. بتمنى ان هم يكونوا استمتعوا بالمحاضرات القيمه من بروفيسور جون، بروفيسور يو. بتمنى لهم يعني يكون يوم جميل ان شاء الله. بشكرهم شكر كبير جدا على المشاركه، سواء كان بقى من ابنائنا المعيدين والمدرسين المساعدين وطلاب الدراسات العليا وطلاب مرحله البكالوريوس في المنصوره والجامعات الاخرى. وشكر موصول لكل من شارك وساهم في نجاح هذا اليوم الجميل.
شكرا جزيلا. شكرا جزيلا. Thank you, Dr. Yu. شكرا دكتور صلاح. Thank you, Dr. Yu.
Thank you.
Thank you, Dr. Yu. Thank you very much.
Nice meeting you.
اوكي. ودلوقتي احنا ان شاء الله هننتقل للمحاضره الاخرانيه. Professor Flavia Rodriguez from Brazil. I think we are going to the next China. Thank you, Dr. Yu. Goodbye.
Bye bye.
Bye bye.